the LSU Health Foundation website and also our social media. Okay. All right, we've got a good number of people coming in. This is great. Okay. Okay, I think we can get started. Oh, there's chat. And I will put up our... And just so y'all know, you can get CME credit for this. We're asking that you please change your name on your Zoom to your LSU email address. Okay, and I will pull up your slides, Dr. Springgate.
Did we post the CME slide already?
One moment. Okay. Goodness, you would think this is my first time. How many more difficulties am I going to have? Okay. So
Not
here
my
is the
slides.
information you, what's that?
Not my slides.
Oh, yeah.
There it is.
Here's the CME slides. And I'm going to pull up Dr. Springgate's now.
All right, hello everyone. Welcome to our webinar series. I don't know which one this is as well as I know what day it is anymore. But we are joined today by Dr. Ben Springgate, who is the Associate Professor of Clinical Medicine and Health Policy and Systems Management. He is also the Chief of the Section of Community and Population Medicine, as well as the Director of the Center for Healthcare Value and Equity. Thank you for joining us again, Dr. Springgate. It's a pleasure to have you on.
Thank you so much. I'm so glad to be here.
Well, take it away.
All right, will do. Well, thanks for joining, everyone. I hope that everyone is as well as can be during these ongoing difficult times. Our discussion today is going to be on the impacts of the COVID-19 pandemic on health services delivery, including policy, practice, and a tad bit at the end on medical education. Next slide, please. Next slide, please. There we go.
Oh, I'm sorry.
There we go. It took a second to go through. Thank you. So the COVID-19 pandemic has dramatically and rapidly transformed health services delivery across the country and certainly around the globe as well. This highly infectious and deadly novel pathogen has created more than 4 million cases, which have been diagnosed worldwide, with many more presumably undiagnosed at this point. And there have been more than 80,000 attributable deaths in the United States. It's also thought that that is a low estimate. As a result, clinical service organizations have reorganized substantially. We've seen in the inpatient or hospital environment that intensive care units have been expanded and reorganized. We've seen the development of COVID-19 wards. We've also seen reassignment of personnel and specific COVID-focused teams have been put in place. Code teams managing cardiopulmonary resuscitation have been modified, and a variety of other personnel changes have been put into place as well. On the outpatient basis, we've seen substantial consolidation of clinics and changes in how clinics are staffed and managed at this point. And home-based services, such as home health, have also been substantially reconfigured. Next slide, please. This has all led to a number of policy responses in the United States. One of the major policy responses is the Coronavirus Aid, Relief, and Economic Securities Act, or the CARES Act. Initially and on an ongoing basis, because of the challenges that we faced in terms of shortages of critically needed materials such as personal protective equipment, various supplies associated initially, for example, with ventilators, and the challenges of particular medications, as well as other needed supplies. The government instituted through the CARES Act additional government oversight and industry reporting to ensure that there would be adequate medical product supplies, that the supply chains would be robust enough to meet this challenge, and that the strategic stockpiles of these critical components would be managed appropriately and sufficiently. We've also seen, as a result of policy changes, the expansion of insurance coverage in some instances, COVID-19 testing, prevention, and eventually, when available, vaccinations are now covered. Health insurers, including Medicare Advantage programs, are now required to provide 90-day prescription eligibility or availability during the emergency. And health plans increasingly are now able to provide, including federal health plans, to cover telehealth services, which are, of course, a new and critical component. Next slide, please. We also saw through the CARES Act additional aid to community health centers, support for rural health services. We saw limitations of liability similar to a Good Samaritan law, which exists at the state level for COVID-19 emergency response among clinician volunteers. We additionally saw a 20% add-on payment to hospitals for treatment of COVID-19. And expansion of telehealth services delivery. It's still showing the prior slide, Sam.
There we go. Sorry.
Thank you. There have been, of course, many additional changes as well. Telehealth expansion for the treatment of substance use and opiate use disorders has been put into place, which is critically important during this time of the ongoing opiate crisis. Medicaid changes have been implemented on a state-by-state basis to increase reimbursement flexibility as well. And it's estimated that about $175 billion in federal aid to providers has been approved by Congress and signed into law. Next slide, please. With all of the changes that we've seen and the dramatic caseloads that we've seen for COVID, we've also seen tremendous decrements in the number of total clinical encounters, emergency department encounters, elective surgeries, non-COVID-19 related hospitalizations, home health visits, prescriptions used, childhood immunizations. All of these have experienced extraordinary declines. And that, of course, has led to or contributed to, what is probably a substantial problem for many patients who are not affected by COVID-19, which is that access to their usual sources of services are diminished, and they may not be receiving their usual services in a timely manner. We can anticipate that the common significant health needs are essentially unchanged in terms of population level of need. And meanwhile, there are significantly rising levels, as in some other disaster type scenarios, for the need for behavioral health services, some mental health services, as a result of the increased stress, as a result of the social isolation, as well as services for substance use disorders. Next slide, please. The decline in availability and utilization of health services in the country has then led to a decline in the spending rate, and that has a tremendous economic impact. Healthcare spending, according to the Commerce Department, declined at an annualized rate of 18% in the first 3 months of the year. That's the largest decrease since these statistics started to be tracked in 1959. And the declines, of course, because of the way that the pandemic spread throughout our country, were probably concentrated in March as the outbreak spread across the United States. Healthcare spending declines were then a major factor in driving the annualized 4.8% decrease in the US gross domestic product, which has been documented through the first quarter of the year. And an even worse decline in terms of gross domestic product is projected for the current quarter, with Morgan Stanley projecting a 37.9% drop in second quarter gross domestic product. Many health systems are reporting revenue declines of greater than 50% at this point, which is, of course, unsustainable for virtually any business over a long period of time. We can anticipate, next slide, please, there you go. We can anticipate that there are going to be adverse impacts to population health. There are a similar number of, presumably, of heart attacks, strokes, cancers, and other illnesses needing treatment at this point. Declines in access to diagnostic testing because people are not going into the hospitals or clinics as a result of closures, stay-at-home orders, as well as people's worries and concerns and fears about being exposed, can lead to delayed diagnostic testing and the progression of illness. Delayed treatment, of course, can lead to increases in morbidity and mortality, and decreases in preventive screenings and immunizations mean that a variety of different significant health challenges, such as cancers or infectious diseases, which might otherwise be detected at an early stage or prevented entirely, may now have the opportunity to progress. Next slide, please. So, with all of the negative aspects of the changes in health services utilization, there, one might also wonder, just as to provide a counterpoint, or to play the devil's advocate for a moment, is there an opportunity for an improvement that's associated with all of these changes? Is there a silver lining here, despite all of the bad news? The costs of healthcare in the U.S. Historically are far higher than around the globe among developed countries, while population health is worse. About 18% of our gross domestic product in the United States, or which totals $20 trillion, so about 18% of that is healthcare related. And declines in services, of course, are felt all across our economy. However, the Institute of Medicine now, the National Academies of Medicine, has estimated that 30% of health services that are delivered in our country, or another way of thinking about this is 30% of that 18% of the gross domestic product offers no value to patients. So that means that the benefit to patients does not exceed the potential risks in about 3/10 of all care that's delivered, and for about 3/10 of all the costs. So that's an enormous waste of resources, and also has an enormous potential for a risk of harm. This precedes the COVID crisis. But maybe then, if we're going to have, there's an opportunity to take advantage of this crisis to try to see, are there ways to innovate and to increase value in the care that's being delivered? Next slide, please. So at the times of necessity and great need, of course, innovations can occur. And so we're now seeing innovations in services. Telehealth, of course, has existed for some period of time, but has been fairly underutilized compared to its potential value. Telehealth services have the opportunity to enhance and access and to add a more patient-centered approach with technology such as audio video clinical visits. This can reduce costs of care for the delivery system. If a clinic visit doesn't require having a suite of offices that are fully staffed and maintained, for example, but instead can be managed using a computer. And for the patient as well, who doesn't have to worry about transportation costs or other time out of the home or away from work, or childcare costs for that matter. There's an increased likelihood now for a variety of forms of remote early assessment, monitoring, and treatment for illnesses. And there's the potential, of course, as well for population health monitoring, for COVID affected patients, as well as those who are at high risk, for whom coming into a clinic or hospital may not be advisable if it can be avoided at this point, or for other high risk conditions or populations. Next slide, please. So as examples, among the opportunities for remote monitoring and treatment at this point, hypertension can be monitored remotely and integrated through the internet into an electronic health record. Notice could be provided to a doctor or a clinic about a person's blood pressure being out of control through such systems. And this is readily available technology already. It simply hasn't been utilized as often as it might. For diabetes, glucose monitoring can be similarly transmitted directly to the clinic or healthcare team. In congestive heart failure, gains in weight can mean water weight, which can mean a worsening of the heart failure, and worsening oxygen saturation also can be a real challenge. For those patients who are, of course, recovering from COVID-19 or presently affected by COVID-19, one of the key measures that the clinicians and hospital teams are looking for, as well as the outpatient teams, are the pulse oximetry, or the percent oxygen saturation in the blood. And that's something that can also be monitored remotely from someone's home, and which can be automatically downloaded or uploaded rather into the electronic health record and with notice to clinicians. And as we are facing all of these increased stressors, not only from the pandemic, but also from the economic conditions that are really leaving many people staggered across this country at this point and around the world, we can monitor symptoms of common and severe and potentially disabling conditions such as depression or anxiety or PTSD, also substance use, remotely. And when people are doing worse, their clinicians can be notified, or they can be linked to care sooner than they might otherwise if they were sitting at home in relative isolation or not able to get to clinical supports, or for that matter, non-clinical supports. We also see, as a result of the increased needs, innovations in the awareness of public health among the general population, personal protective equipment and universal precautions to prevent infections, which historically have been something for a healthcare setting, are now becoming nearly universal, so to speak. Infection control is really becoming an activity of daily living, wearing masks, frequently sanitizing, or regular hand washing, for example. We're also seeing innovations in terms of means of production or reuse of personal protective equipment and production of sanitizer. And these types of innovations are important given not only the current pandemic, but also the risks of future infections, emerging pathogens. And we're now seeing, that clearly visible personal behaviors like mask wearing are viewed publicly as a pro-health and social behavior and are becoming normative. And that's really positive as we seek to try to control the current pandemic and as we're moving forward with ongoing risks of future pandemics. Next slide, please. We also see, as a result of the shifts in the emerging changes, the opportunity for innovation in how our healthcare providers and healthcare teams are cared for. The clinicians on the front lines in hospitals are experiencing, as well as first responder settings, are experiencing high personal risks and repeated trauma. And this is an area that, while we have focused on it to some extent as a profession or as a group of professions in healthcare up until this point, there's certainly an ongoing need to re-emphasize that focus and to redouble that focus, supporting clinician, trainee, and employee well-being and resilience both during and after the present pandemic. This can include doing things like proactively screening for symptoms, as well as providing clinical and non-clinical supports to people to decrease burnout, which has been a substantial challenge in the last decade plus, well documented in the literature and certainly in the experiences of our colleagues. but also the risks of clinical depression and post-traumatic stress disorder and even suicide. And there are certainly, unfortunately, a number of instances of all of these things being documented during the pandemic as a result of the experiences that people are having on the front lines. We also see, as a result of the necessities that are emerging out of this, or an increased recognition, again, of the health disparities based on race and ethnicity. And these are being brought into sharp relief with COVID-19 here in our country. And the pandemic provides an opportunity for us to consider, how do we prioritize health equity as a nation and as systems, and really try to articulate multi-sectoral policies and to fund systems level programmatic interventions to address health equity. And strategies have been proposed and need to continue to be proposed and really realized to try to integrate social determinants of health, things like employment or housing or experiences of racial discrimination, public health and healthcare, as well as health professions education with an explicit focus on racial equity. Next slide, please. And initially, we're seeing substantial changes in how medical education is being provided. The early impacts include that clinical rotations for students are transitioning to telehealth and technology-based formats. This is not only to reduce the exposure to the students and trainees who may be at risk of COVID-19, and in schools across the country, including here in Louisiana, students and trainees were among those exposed, did have to enter quarantine, and some did become sick. It's also to reduce the use of personal protective equipment in a time when there are ongoing shortages of personal protective equipment. But this also can be thought of as a way to spur novel means for improving our teaching and assessment. And I know that our medical educator leaders and colleagues here at LSU are really focusing on this opportunity. Frequently, fourth-year students prior to residency go on external rotations, and they set themselves up for interviews, and they have what's called sub-internships in order to essentially act as if they were interns in their potential residency settings. But those are now being rethought to reflect the changes that are required due to the prioritization of trainee safety. And as we continue to move forward, we also need to emphasize, as much as we do for the clinicians and employees working on our healthcare teams and healthcare settings, we also need to emphasize the wellness and resilience supports for our students, as well as residents and fellows who are navigating these emerging stressors, whether they're COVID related or otherwise. A lot of our students' families have been impacted directly by COVID. Some have not been able to attend, for example, funerals of their loved ones. We've also seen, of course, substantial economic impacts among families in every community across the country, and that is going to certainly impact our students and trainees as well. And then lastly, the opportunity that's afforded by this crisis to try to address health equity and health professions education has perhaps never been greater. So while we have seen tremendous impact of COVID-19 on our health, on our population health, and on our healthcare delivery systems, we have also seen, as a result of this, a number of different innovations. And as we move forward, as we try to mitigate the negative consequences, both for population health and for the health systems, and the well-being of our healthcare teams, clinicians, and trainees, we also need to try to think about where the next levels of innovation are going to come from, and how it is that we're going to take advantage of the moment to improve what we have had up until this point. I really appreciate everyone's time. Thank you for listening. My contact information, including email and cell phone, are on the final slide, and I'd be happy to take any questions.
Thank you, Dr. Springgate. We are taking questions. You can just type them into the chat feature at the bottom right hand of your screen. And while we're letting people enter some of those, I actually have a couple. You mentioned the changes to prescriptions, like making them all 90-day, making prescriptions for 90 days available. Do you think that those are all pretty positive changes, like those kind of changes that have come about?
I think, yeah, certainly, we've known for a long time that that one of the barriers to adherence in medication is certainly whether or not someone actually goes month to month to pick up their prescription. So one of the strategies that's been put in place by organizations that are focused on generating high quality care and population health management and value in care has really been emphasizing things like 90-day prescriptions. Anything you can do to reduce the barriers for patients really makes a difference in terms of likelihood of adherence to medication and hopefully then control of their health conditions. So that, as well as things like the availability of telehealth services, reduces barriers. If we only check blood pressure twice a year when someone comes in the office, maybe once a year, it's a lot harder to manage that than if we're doing remote monitoring on a daily basis. And you can imagine, all of the instances of heart disease or stroke or chronic kidney disease, which might theoretically be reduced or prevented as a result of having better control of blood pressure on a daily basis for large segments of that risk population.
And how are you monitoring that daily, the blood pressure?
So one of the new opportunities that presents itself through the recent policy changes are there are now federal grants, one of which we've recently applied for through LSU Health to enhance availability and access of, for example, internet integrated blood pressure cuffs, so that a patient who is at high risk of having poorly controlled blood pressure, has maybe multiple other risk factors, history of heart disease, or whatever the risk factors may be, receives an integrated blood pressure cuff, receives instruction on how to use that, simply takes their own blood pressure at home every day, much as they might use a home blood pressure cuff that they could buy at Walgreens, but it uploads the information directly to the health record. Okay. And so by virtue of that, that really provides an opportunity for ongoing monitoring and improvement in outcomes.
Right, and I know that some of the newer insulin pumps with the constant glucose monitoring features, those all can upload people's results, like their blood glucose levels daily. Right. And so now, in our application that we put into the Federal Communications Commission, and similar to many others around the country who are applying for this opportunity from the federal government, devices such as that, or scales or pulse oximeters that can connect directly to the internet and bring that information directly to the doctors or the clinic's attention or to the hospital's attention, are really seen as an opportunity. The other thing that's come out of this is that those services, that remote monitoring for the first time is reimbursable. So now the federal government has said, okay, we will provide $69 a month if you monitor blood pressure remotely for our patient on a consistent basis. Oh wow!
And that provides a novel opportunity. Okay, if we're having to consolidate or shrink in the current environment some of the health services delivery because economically it's not affordable to keep so many clinics open when patients are coming in to utilize the services, well then maybe that provides an opportunity to provide even higher quality services or more timely services directly where the patients are.
Right. And I was just thinking about I was thinking about the tools that like Toro has one. It's the My LCMC Health and like My Ochsner. The little portals that you can talk to your doctors through there, you can talk to your healthcare providers. Do you think a lot of people are using those now? I mean, even before the pandemic, were those getting a lot of use?
It's variable. Some were getting regular use and some less so. And it's really sort of on a system by system basis. Some organizations have really gone full throttle and invested in making sure that that's a commonly used and accessible portal for communication with patients. But now we can anticipate, in addition to those portals, as a result of this remote monitoring opportunity, if I want to utilize. There are platforms that we work with in some of our research programs, for example, where if I want to send a text message to a person, a secure text message to a person to click, they can then report on symptoms of depression or anxiety or PTSD, for example, or they can provide direct qualitative feedback, or they can provide pain scales, or they can provide a lot of information directly back into the health system's electronic health record and to notify their clinician or their clinical team without having to go to the trouble of actively seeking out the login opportunity to get into the patient portal.
Right.
It just comes to their phone, right? And it's a text message based application. So this is really a novel opportunity that's going to increasingly become, I think, a part of the fabric of how health services will be delivered moving forward.
Right, and I know I love to confirm my doctor's appointments via text. It's so easy.
Right.
And we have another question from a viewer. So you state that telemedicine is seeing new innovation and popularity as a result of COVID-19. Some naysayers would state that telemedicine is still limited in the care a physician can provide, specifically when attempting to diagnose a new condition. Should telemedicine be more limited to monitoring of known diagnosis and medication check, or are there guidelines that outline what visits should be telemedicine versus in person?
I'm not aware of specific guidelines at this point that make that determination, and it's certainly the case that there are some conditions for which having the opportunity to be face-to-face with the patient in the same room and conduct a physical exam, for example, palpation, auscultation, a variety of other elements of physical exam really do make a difference, and I do not deny that. This is another mechanism, however, and so there are a number of conditions, whether it's for ongoing care or even for new diagnoses, which probably can be managed remotely. But I agree with the question from the viewer in that there are a number of conditions for which the opportunity for physical exam should be, or if in-person face-to-face interaction should be prioritized. And to my knowledge, there are not specific guidelines that delineate those types of questions at this point. It's really left to patient and clinician judgment at this point.
Right. Okay, I think that is all of the questions that we have. I really want to thank everyone. Thank you so much, Dr. Springgate. This was very informative and very interesting. Oh, wait, I think we got one more. No, that's it. And we really appreciate everybody attending today. The recording of this, I know a lot of people like to watch the recordings later, so it'll be on our website at lsuhealthfoundation.org/coronavirus. And our next webinar will be this Friday with Dr. Lau, and he'll be talking about vitamin D and the coronavirus. So we hope you can join us then. And thank you, everyone, and have a great day and stay safe.